from a practical standpoint, and we could throw this question open to the entire panel, what's your experience with giving chemotherapy after immunotherapy? Do you think that these patients are more responsive, about the same level of response? Should these drugs be given together or in sequence?
Well, I would just say that, I mean, again, being one of the older members of the panel, for 40 years, first-generation immunotherapy followed by chemotherapy, there have been reports in all solid tumors and some hematologic neoplasms of unanticipated levels of activity, never validated in any meaningful way, always anecdotal, but lots of anecdotes. I think there's likely to be something there because now we're doing prospective studies. For the first time, we're actually going to be able to see some of that because, in a sense, some of them are going to ask the question indirectly because some of those patients will roll over to subsequent therapy. I suspect we will find something there. I suspect the mechanism will be variable. I don't think it's going to be one answer.
I think we have to be very careful, though, because those who respond beautifully to immunotherapy, we know respond for a long time. And so if they're well enough to get the next therapy, that's a very selected population.
But it might be the patients who actually don't respond who then subsequently get chemotherapy.
That, I think, is a more interesting
Yeah.
question. And I think
Right.
parsing that, though, is
very hard.
challenging.
Right.
And while I know we all may have anecdotes to share, I think it's important
Oh, no.
to really
Surely
look at the
anecdotal.
data
Right.
and see.
And patient selection is really, as you're
Right.
pointing out, is crucial because if
Right.
somebody's progressing so rapidly that they can't get chemotherapy, that's a very, very
So
different patient.
among the progressors, there will be more dropout than among the responders,
Yeah.
right? And so if you can turn one of those around, that would be impressive, but we may have a smaller pool to look at
Well,
for
the other
that.
question that we have to address is, we've been talking about cis ineligible in terms of frontline.
That's
So
right.
the question is, how do we begin to think about
Cisplatin.
moving this therapy? How do you ask the question when you know you can cure a small subset? How do you do that kind of study? Because I think we'd all agree that if you can cure people using immunotherapy, we would prefer that than giving cisplatin. So that's another challenge.
All 3 randomized trials allow cis-eligible patients.
Yep, exactly.
But who puts people that are potentially curable on that will be somewhat biased, perhaps, right?
I want to put a note of caution here, though, for the treating oncologist, and that is, let's take a look at your trial with Atezo first line. Sure. And the response rate was 23%, but the survival is 16 months, right? We go back to the trial you just talked about, and that is Maria DeSantis' trial of CarboGem. Response rate's 42%, and the survival is 9 months. And so this issue of switching therapies for non-responding disease is something we have to be very careful about in the community, because I think we are looking at different criteria for success, and it may not be an immediate response. There may be patients who have stable disease for a while, and so I would caution this switch of therapy in the non-responding patient, as these drugs may become available.
So I think where we're going to get help is when the trials come through where we've got a comparator arm of single agent immunotherapy. So we'll then get to follow the patients and see what happens. I think the issue for the treating community oncologists now is not necessarily the stable patients or indeed the ones that are responding. There are different questions there: when to stop, how long to treat. But for the half of the patients that will blow through, your community oncologists are sitting there saying, this is a new therapeutic paradigm for me using whatever checkpoint inhibitor. And I think the message that I give them is that chemotherapy still does appear to be effective, but it depends on what's going on with your patient. So that performance status 2 patient or 2.5 patient that you put on who doesn't respond. We all like the anecdote of the guy who's hunting near Rob Dreiser's house. He's out there doing everything.
That's why I wear orange in my backyard.
Okay, right, good. All right, very good idea. But for the other patients that you treat, the half of them that blow through, I think the message I give them is you need to work out whether we go back to what we've done with poor performance patients before. Are they a palliative care patient? Are they a one-drug patient where you think you can get it in and get a response and it might help 20% of them if you're lucky? Or are they a 2-drug patient where you should be giving them, say, carboplatin and gemcitabine? I think that paradigm still fits. A lot of the times we sit there looking at the patient saying, is this pseudo progression? When the patient's albumins drop from 4 to 3, they've become anemic, and clearly their performance status is on the frets. When we need to make that kind of decision, I think carboplatin, gemcitabine, the taxanes still seem to be active in a proportion of patients, and they can get a good response. And we do need data on this, but for the treating oncologist who's sitting out there, you need to go back to not being hypnotized by the checkpoint inhibitor when the patients are progressing, and make those decisions on chemotherapy. And you can get a response which, in my experience, is durable to the level of experience of, say, 6 months in a subset of patients.